remember that particular ChatGPT was built to satisfy user, right? So it will generate a response that satisfies you. That always doesn't mean that that is true. I'm more scared about the coming generation because I know like some people, they even don't try to learn anything new. They cannot even calculate like a normal sum or subtraction operation by themselves because they think that, oh, but we have the automated tool, why we need to learn that? But you need to learn the fundamentals. Okay, that you can do this operation in a computer or in a calculator, but you first have to learn the fundamentals. So for radiology, it's the same thing. You can do the diagnosis, you can do the prognosis, but they have to first learn how to do that by themselves, and then you can do it in automated way. You really need the medical experts to understand is that what program can be solved by AI and what problem cannot be solved by AI, and how to validate the AI. I think that is the only understanding that they need to develop when they are working on AI field.
All right. So, hello and welcome everyone to who's ever listening to this particular podcast. I am today at ASU Health Future Center with Professor Imon Banerjee. Dr. Banerjee is an associate professor at Mayo Clinic in Arizona, working at the intersection of AI and healthcare research. Her research focuses on multimodality fusion, mitigating bias in AI models, specifically in the context of medical applications, and more broadly, building predictive models using different data sources. Before joining Mayo Clinic, she was at Emory University as an assistant professor and also at Stanford as a postdoctoral fellow. So, Dr. Banerjee, thanks for being here. It's nice to chat with you today.
Yeah, thanks for inviting me.
What was your entry point in AI? So you have your background in bioinformatics for a very long time, but how did you specifically enter the field of AI, which most people know nowadays, and more specifically, how at the intersection of machine learning applied to medical research?
Right. So I started my career in computer science. So I did my bachelor and master in computer science, where there was no AI involved. But then, starting from my PhD, I was a Marie Curie fellow in Italy, actually, and I started working on the computer graphics for building a solutions where we wanted to analyze the MR images, like magnetic resonance images, and we want to see if the patient has any erosions of in the bone of the joints. And computer graphics plays a cool role there because in the joint is a very particularly the wrist joint is a very complicated body part of the human because you have like multiple bones are like stacked together in a particular fashion, and when you move the wrist, actually the movement is kind of like one bone is moving with another bone is moving with another bone. So this kind of like very interesting animation computer graphics problem. So before I started my PhD, everybody was like doing that, but it's more with like a traditional computer graphics area that where they are drawing the graph and just understanding the simulation with the graph. But then when I started that time, the AI was like fast introducing with the deep learning and everything. And so in that case, we saw a kind of very good applications of AI on that domain and how to model it. Then we build a whole platform from starting from end to end, starting from the MR segmentation, getting the bones, identifying like different surface properties of the 3D bones and how to model their interactivity, and finally, if you can diagnose the osteoporosis or something from the bone movement and the bone shape. So that was kind of like end-to-end pipeline that I did in my PhD. That actually really encouraged me and shows me an application, and that like the framework was actually kind of like like became very popular among the industry and the physicians to be like pick it up. So that actually encouraged me to go towards like more healthcare domain, and I see an application of computer vision because my expertise at that time was both on NLP and computer vision. So I wanted to find a position in my postdoc where I can do both NLP and computer vision. An obvious solution was actually to look for like multimodal healthcare data. So then I moved to Stanford as a postdoc, and I started doing all these multimodal healthcare related projects. And then I become a research scientist at Stanford. Then I became an instructor in Stanford. So I stayed at Stanford for a long time. Then I moved, of course, in Emory and Georgia Tech and to open my own group. Yeah.
Yeah. And you have been affiliated with a lot of institutes
Mm-hmm.
who are like kind of the leaders developing AI
Mm-hmm.
applications specific for healthcare.
Right.
So Stanford, Emory, Georgia Tech, even now at Mayo Clinic. So compared to, and you started your career much more earlier.
Right.
So have you seen any kind of concrete developments where people are actually using some AI-based solutions,
Mm-hmm.
which is kind of changing or kind of improving traditional healthcare settings?
Right. I don't know if you know that. So there is a conference called RSNA.
Right.
It's the Radiology Society of North America Annual Symposium. So you can clearly see the trend there
Yeah.
because like imagine 2015, 2016, the trend was deep learning convolution. So
Yeah.
you see that all the model is doing classification, segmentation, just that. There is nothing else. Then people realized that only building different models for deep learning convolutions or segmentation is not going to work until you really evaluate the model performance carefully. You show the generalization, you show the model bias, you show the disparities. Until that, these models are useless. Then this whole set changes, and now people that time, like in 2019, 2020, people shifted more towards platform. That okay, people are building AI model, how you can support deploying the AI model in the clinical way. So there were a lot of like platform related product. But now people moved, and now everything is about LLM, right? Or generative model. Like forget about platform, forget about all the things that were existed before. It's only about the generative model. So that is kind of like trend now.
And how much of these research actually translate to practice? So we
That's a
see a lot of.
very yeah, that's a very good point. So you understand like when there is two different ways of translating the product to the clinical workflow, because imagine like if you just take an example of Mayo Clinic or Stanford, there are some internal product, there are some vendor defined product.
Mhm.
So vendor defined product, actually, even if they want to sell it to Mayo or just validate it to Mayo, it has to go through a particular like business model, right? And they validate the model and see if it is satisfying and blah blah blah, and then only they can apply that on the Mayo Clinic actual platform. But it has to be federated, FDA approved, and everything. But for internal product, it's slightly different, because internal product actually it cannot be applicable in the patient like support, but it can be applicable as more like a second opinion to the physician.
Right.
And that actually helps the internal researcher also deploy the product without going through the FDA approval and this lengthy process, because that actually builds us the confidence that okay, this model is working when you actually evaluate on some prospective data, and then you go through the FDA approval to bring the product into market. Because as a researcher, we don't have time to go through this lengthy FDA approval process, right? So for us, the more important thing is that the product is usable, people want to use it, and the product is generalizable and provides equalized performance across population. So we can actually evaluate it on the prospective validation, and then we can go through this FDA approval.
I see. And what would you say are like maybe I'm sure there are more than three challenges, but like if you can rate top three challenges that you think are one of the roadblocks for democratizing AI. So you just mentioned how we have a long process when an algorithm goes from working to like an FDA approval stage, at least in the
Right.
context of healthcare settings. So as a researcher community, what are the biggest challenges you think researchers can work on? One of like I'm like more than me, but it's like fairness of
Right.
these models or maybe bias. What are some other challenges that researchers now face to make models work in the real world?
Right. So there are again. So when you say like make work in the real world, there are two different ways again. So one thing is that you build a very good model that you are very confident that the model is working. You push it into GitHub and let the people use it.
Yeah.
If the model is really good, like probably people will use it. But how many people will actually use all these models that are sitting in GitHub, right?
Right.
How many? Like you can just
The ratio.
count it,
Yeah.
right? Like,
Yeah.
but then there is another route that goes through the FDA approval and you sell the product. But that, as I said, like as a academic organization, is very difficult
Mm.
until you are affiliated with some industry. Because if an industry is interested in like marketizing your product, then only that part is like possible. Because even if you go through the FDA approval, that doesn't guarantee that it is marketizable.
Mm.
So you get the FDA approval, okay, and then what? You know, then you have to put the product in market so that the people can use it.
Yeah.
It's not that easy transition. So that is a big like gap between what we can open source versus what we can actually marketize.
Right.
And there is like no hard and fast rule, right? Ideally the simple products are more popular, and that
Yes.
can be easily marketized, while the complex product is better to do the open source, so that People can use it and give you feedback, and then you can decide which component you want to marketize. So this is the two strategy. But I think the biggest challenge for the healthcare development is, as you mentioned, one is the fairness, because we have to think really, really careful about the fairness, particularly a country like US, where you have a very heterogeneous population. But most of the time, the models are trained on a single institution or even two, three different institutions, but they have a very homogeneous population. So that creates a huge problem when you actually take that product and apply it to another university or another healthcare institution, which population you never seen before, right? So there is no guarantee that the model is going to work. And then that not only hampers your product, but that actually hamper the trust on all the AI model. Because then the physician will be, I talked with multiple physicians, they say like, oh, we applied, we take this product, we tried it, it didn't work. You see that means the AI doesn't work. But that's not the conclusion. The conclusion is that that product didn't work because there are some reason, So I think that is the main thing that the current thing is like we have to increase the trust of the healthcare people on the AI and the application of AI, and the AI can help actually the people more. Because there's also another kind of thought that they are thinking that, oh, but AI will come and all these admin job will be gone, all these radiologist job will be gone. But it's not that. The job will be still be there, but probably the job will be different, right? Like you will not do the repetitive job. You will not do like summarization of the document, because that AI can do, right? So the job is different, but the job will still be there. I think that is another challenge we are facing a lot, to explain that what can be done, what cannot be done.
Right.
And another part is, which is also pretty important, that you have to convince the leadership, right? Whenever you are bringing an AI product, you are pushing an AI product, you have to convince the leadership. So I think the education component is missing. That how to convince a person who knows very little about AI, how to convince a person that what needs to be checked, what needs to be validated, what needs to be implemented, so that this product is useful for us. So I think the education component is also missing, which is very, very important, that the generic audience, whatever their specialty is, they get a generic education on AI.
Yeah. And so, talking about awareness, one other topic which is kind of the trend nowadays is LLMs.
Right.
Everybody is talking about LLMs. So, I've seen a lot of your research in the last couple of years. You have also been focusing on generative AI and LLMs and checking their vulnerabilities of how they work in healthcare research. So, couple of years back, people were mostly focused on discriminative models. So we are trying to only understand if this is healthy or diseased, anomaly or not. And now we have this new explosion of generative AI models. And now on top of that, we have LLMs, which are based on language models. So for these two particular models, in context of any modalities, it could be language, it could be vision. How do you see generative models and LLMs in the context of healthcare research, and what are the current under promises versus over promises? Because a lot of people are scared, a lot of people are overly optimistic. So what do you think, like how do you envision the next 5 years, I would say, in this era?
So I observe exactly as you mentioned. I observe the same thing, that when we talk with a group of people coming from like different discipline, different areas of AI, there are two branches of people: one who trust LLM 100%, and one who doesn't trust LLM at all.
Right.
But I think we have to find a common ground, that it's not like you cannot trust LLM. It's not like you have to 100% trust LLM. You have to find a common ground to understand that what LLM can do, what LLM cannot do. So I can give you an example, that I don't want to mention the journal name or any publication, but there was few publications that we are currently seeing that they are claiming that they can summarize, imagine, a very, very complicated radiology report 100% without any fine tuning, using an LLM. Like it is open source LLM trained on web crawl data. You can summarize the radiology report 100%, but which is not possible, because as you know, that any people who has a computer science background, they understand that the LLMs are particularly not good in summarizing numbers. So if you have a numerical measurements or something, it is they are not good at doing it. You understand, because of the embeddings, because of the how the model was trained, how little the model has information about how to summarize the number information.
Right.
So most of the time the model fails. But that's okay. That's okay. That's how we expect the model to be failed. But if somebody claims that those reports can be summarized 100%, that means that there is some problem, right? There is some problem that people has to evaluate carefully, that why they are mentioning that they can do it 100%, right? And LLM also has some problem of hallucination, that they hallucinate some information, particularly if you are like forcing the LLM model to generate some output, they always sometimes hallucinate information, which is also risky because that needs a manual checking, right? So I can give you an example that we are working with another journal, and so the whole idea is the article written by human, article written by LLM, and LLM can even generate the citations which doesn't even exist in the world because they train with the data and they know like what kind of citations people usually cite. For example, at the beginning of the paper, you usually cite, like for example, if it is a healthcare paper, we usually cite, oh, the cancer is like 100% common in this population. We usually cite like that, right? So they even try to generate, like mimic that kind of citation. So you understand, like it is not about only validating the text. You also have to validate the source of the citation and see that they actually exist. So you can write. So we were debating with the journal that you can write the article. It's not the problem, but then actually your responsibility increases even more. That you have to validate each and everything.
Right.
That means like that is a huge responsibility.
And I think recently it came out, right? Somebody mentioned that more than 17% of the reviews that were published in ICLR, couple of other big conferences were actually based on ChatGPT's recommendations. So I think maybe reviewers are just posting the whole manuscript into a chatbot,
ChatGPT, yeah.
and then they are doing some prompt that can you review this particular paper, and which is a big problem.
Which is a very, very big problem. You understand, right? Because you can use LLM for summarization. You can use LLM for information extraction, the one that already exists, right?
Right.
If you are depending on the model to generate information, like a generative part of the model, that is okay. But you have to validate it very carefully because you don't know what the model is generating. If those sources are like actually like validated, right? So that is a huge responsibility. It's the same responsibility. Imagine like you are in a faculty position and your students give you a paper. It's your responsibility to check each and everything, right? Because if then you publish the paper, if some data is wrong, you cannot blame the student. It's your responsibility to validate everything.
Right. And related to this, there's also a debate on understanding how these LLMs model and what they contain. So a lot of people would say that these are next word predictors, which is what the model is trained to do. And some people claim that these LLMs can also have like a very dense or compact version of the world knowledge. So it's like a world model, at least in terms of language modality. So what do you think in your personal experiences and maybe what you're training as a computer science student, do you think LLMs really have like a structure of what language means to us as humans, and do they really encompass the world model inside
So it
them?
depends on how you train the model, right? So imagine that you train the model on the PubMed articles. You know at least the knowledge that the model is learning. Probably they are valid because they are published in a peer review article. So somebody peer reviewed it, and this knowledge is valid. But imagine that a LLM trainer web crawl data. You don't know what are the sources. Anybody can publish anything on the web, and the model is trained on that. So in that case, you don't have any control on the source of the data. And that case, if the model is generating something, you cannot guarantee if it is right or wrong.
But I think the debate goes along the point of, if let's say if I'm just training a LLM model on PubMed data only, the knowledge learned, are the model learning some statistical correlations between word vectors, or are they learning actual knowledge that was like written by medical experts? Like, are they understanding what it means to
It
have a
depends on how
migraine?
you train the model, right? If your training of the model is just next word prediction, so you cannot expect the model to understand the world of knowledge, right? If you are training the model in a question answering task, or you're training the model to in a generative task where you have the true ground truth, then you know that okay, the model is learning the true knowledge. So I don't know if you saw that we published a recently a paper where we tried two different attacks on the model. So one attack is actually a very simple attack where we are trying to do a poison data set. So just release like a very few example of poison examples and release it with the mix it with the actual true training data set, and all the LLM models were generating poison outcome. So imagine that now it's such a like dangerous tool if it goes in the hand of a pharma company or something who wants to sell their product, and they will generate these poison examples just like few. You don't need much, you need like 200 300, and when the true example is even like 100,000 and you have 200 300 poison examples, still you can poison the whole model. And you will not know. So that's what we are showing, that you don't even know that those models are actually poison, because the model will be generating the outcome same as you expect. So all the quantitative metrics that we usually calculate, like Rogue score, Mogave score, the scores will be fine. There will be no problem with that. But the problem is that the model will generate some particular poison answers on those particular scenario, which is kind of dangerous.
Right.
So we also did a model editing attack, that we trying to like edit the model weights to generate some particular examples of poison, and we can attack like most of the biomedical model like BioGPT, GPT-2, like any MedPlum, any like popular
Right.
biomedical models. Yeah.
And since you work with a lot of medical experts like clinicians or radiologists who might have limited understanding of, let's say, AI, how would you explain to us, a person who is strictly from medical expertise, how is LLMs or in general AI going to be a part of their workflow that they are currently living in? So because it's a given thing that yes, LLMs will increase the productivity even if you're a medical expert, because replacing your jobs is definitely out of the window. We are not talking about that, but it is going to be in your workflow in
Right.
some way or the other. So like back when then Microsoft Excel came in, nowadays everybody's using it because it's a technical
Right.
bump on your productivity. So to any medical experts, like how would you explain how these particular tools are going to be a part of their life and what they need to upgrade in order to adopt them and use them better?
Right. That's a very good point actually. So it depends on what disciplines you are in, because LLM can be applicable in different discipline differently. So let's take an example of radiology, which is a really time consuming task that radiologists actually, I don't know if you know that, like when they read the images in the reading room, imagine like a completely dark reading room. There is no light and people are sitting there for like hours and hours, like minimum 8 hours per day. It's kind of really depressing, right? You understand, like at the end of the day their productivity automatically goes down, because I'm not saying that they are doing some obvious mistake, but if you look at, so there are a lot of studies published that at the beginning of the day they takes much less time to read a study, but at the end of the day they takes much more time to read a study. And that is obvious because you're sitting that in the dark room the
Yeah.
whole day without speaking with anyone. The communication is really less, right? So of course your productivity will go down. But actually LLM can help with that, because forget about the like, image analysis part, but even if we just consider like LLM itself, like language model, so radiology write like multiple sections, right? So first section is the clinical history. So in the clinical history, they have to go back to the EHR, like the electronic healthcare record, to identify the portion of the clinical history that they have to copy paste and put it in the report. Why it has to be done manually? This has to be done automatically, right? Because such a simple task. It's not a generative task.
Right.
It is not. There is no such obvious reason for why this task cannot be automated, because there's a clear cut copy paste. Very less time they actually change the sentence just to make it short, because they don't want to write a huge history in
Right.
their report, so they usually make it so short. So ideally it's like finding the important text and make it short. So summary, like extraction and summary. Why it cannot be done automatically?
Hmm.
Then the next part, which is actual their job, to write the findings from the image. So they look at the image and they write the findings, right? So that portion, I think it needs a human evaluation very carefully, because that actually actual the radiologist's job, right? But then the last section is actually the impression. Impression is basically the summary of the finding. Why it cannot be done automatically, right? Because you already write the full summary and you have a knowledge what you want to put it in the impression. Why we cannot do it automatically, right?
So it's like mostly trying to eradicate human errors and
Yes,
making
exactly.
them
Try
more
to
scalable.
eradicate human error, as well as try to actually spare the human to do this kind of
Yeah.
repetitive jobs,
Yeah.
because finding, copy pasting a history, even a high school student can do that. You don't need a professional radiologist to find the history
Yeah.
for
Yeah.
or the patient.
True.
So this kind of thing, for example, that you work with neurologists, you saw that the neurologists, they, for example, like migraine domain particularly, they write a lot of information about the patient, and if you look at the sequential note, they just copy paste the information in the sequential note
Yeah.
and summarize version of the copy paste, right?
Yeah.
Why it cannot be done automatically, right?
Right. Right. Makes sense. And one other thing before, like I think before the whole LLM trend came in, right? A lot of people who were focusing at the intersection of medical research and AI, the goal was to focus or maybe push scientific discovery. So we are trying to use this complex data sets, complex algorithms to see something that we as humans don't see,
Right.
and try to make some complex pattern analysis. In your experience, you have been, I think, working for a decade or maybe like maybe slightly more than that.
Yeah.
So have you seen, and maybe like as a part of your research, or maybe like if you want to highlight someone's research, what kind of scientific discoveries would you say to a layman that AI is enabling in the field of medical research? So like what is the tangible output that I'm seeing that AI is actually making a difference where humans might have some limitations at some point?
Yeah, I think reading long information, that human has a limitation. So if I give you like 1,000 different time points of a patient, you cannot read it. As a human, even an expert, it's impossible to go back 1,000 time point of a patient to look at the history, right? So that's why they keep summarizing this thing again and again in every notes in sequentially, right? But that can be done by AI pretty quickly. It's 1,000 time point, 2,000 time point, doesn't matter, right? They can read it very easily. Then all these kind of like data, particularly like signal data, multimodal data, combination of this data and creating a kind of combined knowledge from this data is not easy for a human being, because this data is coming from like different disciplines. So they have different ways of reading the data, different ways of interpreting the data. So I think human lacks the expertise actually to read the data from the different field and combine them. I think AI can help on that a lot,
Yeah.
and create a kind of like combined knowledge, which would be helpful for the finally the human physician to go through that. I can give you a quick example. So imagine that, particularly in Arizona, which is a big problem, that Arizona, particularly in summer, we have the problem of sun, right? When it is like so hot, the sun is so on our head,
Yeah.
people tend to develop a lot of like melanoma, which is a kind of like skin cancer. And most of the people, particularly the white population of Arizona, they are aware of that it is very risky. So when you go out of sun, there is a risk that you develop melanoma, because the melanoma usually happens on the sun exposed area. And for that, actually, so they are so scared. So whenever they see that there is some like spot in their skin, they usually go to the PCP immediately, like the primary care provider, for nothing basically. Like it's just a spot, right? Like
Yeah.
it's nothing. It's not a melanoma. But I think it's important. It's important definitely, because you have to make it check,
Yeah.
because just to make sure, because melanoma also there is a history that if you diagnose it early, the treatment is like 100% recovery. But if it is diagnosed late, then the recovery rates actually drops a lot. So it's better to diagnose early, but that actually increase the PCP load a lot. And these PCPs, like primary care providers, they are not expert people to do the diagnosis of melanoma, right? So that kind of thing that AI can do pretty easily. So imagine that if you have a system that you use mobile, you just take a picture and it will just give you that you need to visit a PCP or dermatologist, or you don't need to visit a PCP dermatologist, right?
So the initial screening can
Initial
be.
screening. Initial
Yeah.
screening can be done in home, right? You don't need an expert to do that. And of course, this is not your final diagnosis. You have to go through biopsy. You have to really look at like what is happening. But at least it will give you initial screening that, okay, this is just a mole. Probably you don't need to go to a
Right.
PCP. Yeah.
Right. And would you say AI algorithms are almost at that level that maybe if I, let's say, make a mobile application and people can download it on their iPhones, would you say that if I'm sitting there at home and if I scan that kind of melanoma, there is not a chance, like there is a very low chance that it would be something severe that the model did not detect. So maybe let's say I just sit back at my
So
home.
that is the problem with the fairness that I was telling you before. That imagine that this is so biased. So there are a lot of algorithms already exist. A lot of model already exist that do that diagnose the melanoma or like severe skin cancer, but they are severely biased towards the white population, because it is actually sad to see even in the dermatology books how many picture you see with the other skin color which is not white, right? So the model was also trained on that population that mostly white. So whenever they see any other skin color, for example, brown or darker skin color, and particularly darker skin color, these models has a tendency to detect more like false positives, and which is okay. But in the white, they have more tend to detect the false negative, which is kind
Negatives.
of dangerous.
Yeah.
So you have to create a kind of balance. So the primary thing that we are lacking in those kind of like open source AI model is to test the generalizability. If this works on all the population, I'm fine that the model doesn't work on all the population, but at least mention that the model will not work for this population, that we never tried on the American Indian. So I don't know if it is going to work on the American Indian or not.
Right.
Just mention that. What is the problem with that, right?
Yeah. And one of your earlier works also focus on debiasing AI models, right? So I read this one article. I'm forgetting the title, but it was related to, I think, detecting race
Right.
from vision data. And one of the key things that I like as a researcher, I was trying to understand this thing, because if you see, like, the tendency of any neural network is to always overfit, like it is trying to overfit to a data, and bias is what helps the model
Right.
drive some accuracy. So how do you detect good bias versus bad bias? Because there could be some diseases or anomalies that I'm locating, where maybe race is a factor. Like maybe
Right.
it's a important biomarker to
Right.
understand this disease better.
Right.
So how do you decide as a researcher, or like when we are trying to develop these algorithms, that this is a good bias versus bad bias?
I think if you know the bias, then it's a good bias. If you don't know the bias, that is a bad bias. You know what I mean? Because imagine that you know that, okay, the cardiovascular disease happens more on the African American population, and it's okay the model is learning African American population because it happens more on that population. But we actually proved also on that paper that there is no direct correlation between the disease and the race,
Mhm.
but the model is still predicting race while we are training the model for actually to predict the disease. So that is a kind of bad bias because you don't know that why the model is then predicting race, because race is not correlated with the prediction, right?
But that is the case when we already have some background information. But let's say
Right.
there's a new kind of disease, like I don't know, like maybe something like COVID, like which was
Right.
completely new to the
Right.
databases. So how do I potentially eliminate a biomarker where it could be a potential biomarker versus
Right.
it could be like a biased
So I
biomarker?
think for bias, I as a computer scientist, I can just tell you this because it will sound bad, but that is the truth. That like removing the bias is not the problem. The
Right.
primary problem is identification of the bias.
Yeah. Yeah.
Identification of the bias. Once you identify it, you can remove the bias. You
Right.
can either do the data sampling removal, you can do the in processing removal, you can do the post processing removal. There are multiple computational way
Yeah.
of removing bias. But for us as a computer scientist, the problem is that we don't even understand that
Right.
what is the bias,
Right.
until you really apply on a large data set and manually evaluate everything. And you know that. So I can give you an interesting example that we were doing a study where we are predicting a cardiovascular outcome from the chest x-ray, and the model was working pretty good, but it is particularly failing on some cases. When we look at that, we see that the model is failing particularly for the female, which is expected because cardiovascular disease primarily happens on the male population. So model is of course predicting the male from the chest x-ray and saying that, okay, the male population have more high chance of cardiovascular disease. So we reduce that bias. We reduced this bias. We did all the in processing and everything. So now the model is not failing for the female patient, but there was another some patient model was failing again. So we started checking and we saw that there are some patients who are going through some hormonal therapy, male, and they have some breast tissue. And the model is particularly failing for those patients because those patient has breast tissue,
I see.
which is kind of very interesting. But they are male, but breast tissue, but the model is failing. They don't know, like, okay, I learned gender, but I don't know how to use it because this is a kind of like unusual situation.
Right, right. So this is like the case where you're trying to discover something, and this is where I think the
Bias,
classic
discover
example,
bias, right,
yeah.
is a very like classic example that bias discovery is not sometimes kind of like unreachable because
Mm,
how many situation we evaluate, because this is a very rare situation that the male patient has breast tissue.
yeah,
So it's a very rare situation, so you can go like up to a certain point that
yeah.
you have time and analyze the moral bias, but after that, like, you
and,
don't
and
know.
and one key thing, like, because like you are saying, like you are sounding it more easy, but I think this idea of like understanding how the bias happened and
Right.
the whole interpretability field is much more underdeveloped in the field of
Right.
AI, right? And when it comes
And
to
particularly
vision,
for healthcare.
yeah, particularly for healthcare. So which methods do you think are kind of almost, like, because a lot of people have critiqued like methods like Shah,
Right.
even GradCam,
Right.
which are like very prone to
Right.
attacks, and also like the not with attacks, even without attacks it's not very reliable. So which methods do you think are slightly acceptable in the healthcare settings, which can help you understand if the model is biased, like the predictions are biased or
I
not?
think generalizability. You have to test the model generalizability outside the population that you train the model, because
Mm,
then only you understand why the model fails. Because if you just keep testing and validating on your data set or a split from your data set, which is a holdout test,
yeah.
you will never identify the proper bias. Because let the model live on the real world
Mm,
and then see what are the bias. Because you are training the model, testing the model on a very controlled environment, and you don't know what is the real world bias.
mm.
You have to let the model live in a real world to see the actual bias.
Makes sense. Makes sense. And what the one other trend in the broad field of computer science or AI is how people are focusing more on scale
Mhm.
rather than architecture. So I think I started my PhD around 2020. Before that, I was doing my own homework of like what AI is, and people were trying to come up with new techniques like zero shot learning, one shot learning, transfer learning, which were like kind of the new trends. Like, okay, I am trying to move towards more efficient AI models. But now people talk about bigger models, bigger GPUs, bigger amount of training resources, fine tuning LLMs. That's the only thing people talk about. So, do you think this trend is here to stay, because nowadays, even if you see people from academia or researchers try to focus on LLMs and research on top of LLMs. So do you think like people are still focusing on architecture based AI developments, or like scale is going to be the big thing? Like scale is here to stay, making the bigger models, and that's how things work.
No, I personally believe that the model architecture needs to be updated continuously, because we also see like there are multiple paper published recently on the LLM domain itself, that there is a saturation point, right? You keep increasing the layer, but at one point of time there is a saturation that even if you add more layers now, the model performance is not going to improve, right? So in that case, this saturation point is almost there with all these Excel models, so it's almost there. And then the field will come back again to the model development, because then adding more layer is not going to help to improve the model performance. Yeah.
Okay, makes sense. And as your personal agenda, like I don't know if you have a personal motivation statement, but let's say if I were to ask you, what are your three key points that you want to focus on your research in the next 5 years, that okay, I'm working on this and I want this problem to be solved, which people might know or people might not know because they are not into the very nitty-gritty details of AI and medical research. So what are those 3 points that you broadly try to address, and how you have been doing that?
Yeah, so I personally wants to like really focus my work on the on this kind of like model debiasing and fairness. And we are doing a lot of work on even unknown bias, where the bias is unknown but still you want to solve it. So this kind of like unknown bias. And another space I really want to understand is the vulnerabilities of LLMs and with different model attacks, and how we can prevent those attacks, particularly when the models in the hand of um, even like layman person, or even on the hand of kids, which is kind of like really dangerous. You don't know how they are going to use it because they don't have any knowledge about that. I even see like some kids recently that they are doing their homeworks using LLM, right? Like, so this kind of thing that you have to, I don't know like what are the best solution, but we are working towards that. And then another direction I really want to, I'm working actively, is the education, that we are building a lot of like educational components with RSNA, with SER, in Mayo, so that we can increase the awareness of how to use, how to validate the AI on different scale, starting from like even admin level up to like the leadership level.
I see, I see. And I wanted to also, normally a lot of people, you work with a lot of students, so you see a lot of different kind of energies when people join your lab, or even you have been student in the very recent past. So what kind of advice you would give to students who are getting started? Because when I started in 2020, it was pretty much a saturated field, but that was the time people were talking about transformers or models like that, and it's very easy to flow into the trend. Because when I was getting started, I would always wonder, do vision transformers really outperform CNNs? Should I focus my research on learning attention modules versus convolution modules? So it's very easy nowadays to follow someone on Twitter and get intimidated by what's going on in the trend. What should I be focusing on? And there's not a very clear direction. So if I were to pick LLMs in medical research, like what do I want to focus on? Because I don't understand what LLMs are. I don't understand gradient back propagation itself. So what advice you would give people who are getting started in this field? Like where, if you made some mistakes along your way of like getting into like from point zero all the way to academia nowadays as a senior professor, what kind of mistakes you would tell, or pitfalls you would ask someone to
I
avoid?
see a dangerous trend, actually, honestly, a very, very dangerous trend on the AI, that people claim everybody is like an AI expert, but they don't have a background, mathematical background on AI, which is really, really dangerous. It's okay if you are just AI user. You don't need to have a super like depth mathematical background in AI. But as a student, when you are starting on in computer science PhD or MS even, like why not? And you want to do a research, remember that you need a strong mathematical background. Particularly, you need a strong mathematical background on calculus, differential calculus. You need a strong mathematical background on basic machine learning, like traditional machine learning. Then only all this concept is not like developed from sky, right? They are developed on the primitive fundamental module that we already had in calculus or in machine learning, traditional machine learning, that just build on top of that. Until you understand the traditional machine learning, or until you understand the basic mathematics, you will never able to understand what is the self-attention. You will never able to understand what is the back propagation. You will never able to understand what is the stochastic gradient descent. So you have to understand the basic mathematics to understand those functions and how they work. As I said, like as a AI user, probably you don't need it, but as an AI developer, you definitely need it. Only coding is not enough, so you have to have the mathematical background.
Mhm. And like I have seen this trend, at least like I see in Arizona, like Arizona specifically built ASU specifically built a center for like collaborating between engineering backgrounds versus medical, and I think they are building a medical school also. So it's like kind of merging all the ways together forward. So how much would you say that it's going to be a trend that people are going to be more focusing on awareness or education, like you said, where medical experts in their in their very bachelor level studies are being taught how to maybe code or program? So how much you think technological background is going to be ubiquitous even with medical experts?
So I don't think that the medical experts need a coding background. What we really need the medical experts to understand is that what program can be solved by AI and what problem cannot be solved by AI, and how to validate the AI. I think that is the only understanding that they need to develop when they are working on AI field. Because as you know, like you are working with a medical expert, right? How much code they actually provide to you? Nothing, right? But what they provide to you, which is very important for you, which is the data.
Right.
So they have to understand that if this project is feasible or not based on that data that they have. So you cannot go back and forth that, oh, I need this data, I need this data is not sufficient, and explain them why this data is not sufficient, And sometimes it's very difficult, as probably you already faced this problem, that sometimes very difficult to tell them that why this data is not sufficient because they don't understand, right? Because if you tell them, oh, the distribution doesn't match, or we need more parameters, blah blah blah, and they don't understand this fact. So I think that is the level of understanding that they have to acquire. But you understand, like, another problem I would also, it's not about the complaint about the medical expert, I would also complain about the computer science, because computer science field also has a big disadvantage nowadays, because I know many students that are working on healthcare, they are super deep into computer science and they are super deep into models and architectures but even they are working on a healthcare domain, they never try to understand that domain. You understand? For example, like you are taking into account a very complicated problem. So give you example of your neurology field. So imagine like you want to predict microbleed. It's a very, very complicated problem. And practically identifying microbleed from an image data, something expert cannot identify that. So you have to understand. You have to understand that what is the problem, what kind of data you want to use, and why it fails, and how to improve it, and why we cannot collect more data. You have to understand the actual domain, right? Before you move to the model development, build more layers and add more parameters, you have to first understand the domain problem. That I still remember when we started the first working on the medical field, that whenever I start a new project, I start reading about the domain itself. For example, I started with the pulmonary embolism project with Matt Lundgren, and I spent hours and hours with Matt, and Matt was like drawing in the board to explain me like what is the pulmonary embolism as actually problem, and what are the implication, how it looks in the image. Until you develop that understanding from computer science, you would never be able to work on any project. It would be same as working in an imagined data set,
Yeah, fair enough. And lastly, on the concluding note, I want to ask you a question: is again, you're working in the core of research. You are as a scientist at Mayo, and you also have professor faculty appointments. So a lot of people get into the trends of like understanding, I want to get into AI research, but they might not know what actually lies ahead of them. So who would you say is like an ideal candidate to get into research? Who should do a PhD versus who should not? Maybe it's not a good trajectory for someone.
So I think research is good for anyone who is curious. There is no requirement. It doesn't need any prerequisite skill set. If you are curious, you are good for research. But the curiosity should continue, right? The curiosity should never have any stopping point. So I know some faculties like still in Stanford, in Mayo, that they're 80, 90 years old, but still they are curious to learn a new domain. So in research, remember that it would not be not like working in an industry. You have to continuously learn and still think that you are a student. I still sometimes like I learn from my students, right? You always keep learning. That's the only way to stay in a research. So no coding, no mathematics. The only thing is that you have to have the curiosity. Coding skill, mathematics, you can develop by yourself. You can take a course. You can do whatever you want to build that skill set, but you have to be curious.
Yeah, that's fair enough. Until we have the next LLM who can be equally curious than us. So
you cannot believe, like I even saw some people are asking. Again, I don't want to specify, but like really like experts, they're asking like the LLM to give them idea of research. You understand, right?
Yeah,
So
I have seen a lot of people actually using that to like not just as a text prompt to like correct their mistakes, but using that to get potential ideas
potential idea. So
to
this
like
is dangerous. You understand,
yeah.
right? Yeah.
And personally, like I have not been a fan because I feel I can Google stuff and get answers more easily
Right.
than using chatbot. And I've seen like
But the
personally,
Google will never give you the idea of research, right? If you say like, oh, I have this data set, give me the idea that what I can do with this data set. This is not the job of an AI. This is
right.
a job of a human.
And I actually realized why any LLMs or like ChatGPT in particular is bad, because when I try to put in my question that I was
Right.
trying to solve as a part of my PhD research, the answer it gave, it wasn't even close to being what it
Right.
should have given. So
Right.
that's when I realized that yes, they are great sentence completion tools,
Right.
great tools to correct your grammar mistakes.
Right.
But they are no way closer to being calling like a knowledge world model. It
No.
doesn't understand any statistical or
But that is
mathematical
not the
terms.
purpose, right? The purpose was not to be the world database or
Right,
world idea generation. The purpose is actually to help you
right,
so that you can do your job, right?
right.
So I remember that particular ChatGPT was built to satisfy user, right? So it will generate response that satisfies you. That always doesn't mean that that is true,
Yeah.
right? Like people has two different response. That one response is actually the truth, and one response is we generate to satisfy the other person. That always doesn't mean that that is true.
Right.
But I understand. Like I'm more scared. I'm more scared about the next generation.
Yeah.
I'm not scared about our generation or your generation because you have seen the development. You have known the positive and negative side. I'm more scared about the coming generation because they I know like some people they even don't try to learn anything new. They cannot even calculate like a normal sum or subtraction operation by themselves because they think that oh but we have the automated tool, why we need to learn that? But you need to learn the fundamentals. Okay, that you can do this operation in a computer or in a calculator, but you first have to learn the fundamentals of what is the function, right? Then you can do something on your on
Yeah.
the automated machine. So that's the only thing, right?
Yeah, I
For
think that
radiology is the same thing, right? Or medical profession is the same thing. You can do the diagnosis, you can do the prognosis, but they have to first learn how to do that by themselves, and then you can do it in automated way.
but yeah, I think we covered a lot of questions in general. And it will be very useful for people who are sitting at the intersection, how to move forward, what are the current challenges and what are the current limitations.
Right.
So thanks a lot for being here. I'll be posting a lot of links to your research work, so people who
Thank you.
can check out this podcast can also have a reference what we are talking about. But thanks a lot for being here, and I appreciate that.
Thank you.